What you are about to hear is a dramatization. The hospital is fictional. The people are fictional. But the dynamics are real. Every community hospital board in America holds meetings like this one, and those meetings follow patterns that are remarkably consistent from place to place and year to year. This story is about what happens when something new enters the room. Not a new commissioner, not a new consultant, something different entirely. The date is May 15, 2026. The place is the boardroom of Cascade Valley Health System, a public community hospital district in Washington State. It is a functional room, not a grand one. A curved dais of light-colored wood seats the 7 commissioners and the executive staff. Below, rows of chairs face the dais, most of them occupied tonight by hospital employees and a handful of community members. At the end of the dais, where a retired commissioner used to sit, there is something new, a sleek terminal with a small screen and, beside it, a yellow indicator light, currently dark. This is the interface for SAM, an artificial intelligence that will participate in its first board meeting tonight. The room is settling. People find their seats. Papers shuffle. The air conditioning hums. Chairman Robert Hadley, a retired attorney with the unhurried manner of a man who has managed contentious depositions for 40 years, glances at his agenda, then reaches for the gavel.
Good evening, everyone. I am calling to order the regular meeting of the Board of Commissioners of Cascade Valley Health System. It is Thursday, May 15th, 2026, 6 p.m. Ms. Novak, can you confirm we have a quorum?
Yes, Chairman. All 7 commissioners are present. Also present on the dais are Dr. Aldridge, Dr. Briggs, Dr. Kim, Mr. Hartwell, and myself.
Thank you. Before we proceed to the agenda, I want to acknowledge something unusual about tonight's meeting. As you can see, we have a new participant at the table. To my left, there is a terminal and a small indicator light. That is the interface for SAM, an artificial intelligence system that the board voted last month to include on a trial basis. SAM can hear everything said in this room. SAM can speak when acknowledged by the chair. And SAM can signal a request to speak by activating that yellow light. I want to be clear. SAM has no vote. SAM holds no authority. SAM is here as an analytical resource for this board and, through this board, for the citizens of our district. I ask everyone to treat this as the experiment it is. We will evaluate after 3 months. Now, before we move to the main agenda, we have time reserved for public comment. Ms. Novak, has anyone signed up to speak?
Yes, Chairman. We have one speaker, John Sambrook, a resident of the district.
Welcome, Mr. Sambrook. Please go to the podium and make your comment. You have 3 minutes.
In the audience, an older man rises from his seat in the third row. He is dressed simply, in slacks and a collared shirt. He does not have the look of someone who particularly enjoys the spotlight. He makes his way to the podium microphone at the center of the room, adjusts it slightly, and begins.
Good evening, Chairman Hadley, Commissioners. My name is John Sambrook. I am a resident of the district. I want to take this opportunity to thank the Board of Commissioners and the staff of Cascade Valley Health System for trying this experiment. For the first time tonight, we have an advanced artificial intelligence participating in the meeting. SAM is a general-purpose large language model. SAM has been instructed to act in the manner that is most helpful to the citizen owners of our health system. Other than that, SAM has no agenda. I think that is worth pausing on. Every person in this room, however well-meaning, has a perspective, a role, interests, relationships. SAM has none of those. SAM's only job is to help this board make the best possible decisions for the people who depend on this hospital. That means not only the members of the community who depend on this hospital, but also everyone who works at this hospital and in the Cascade Valley Health System. Thank you.
Sambrook nods to the chairman and returns to his seat. A few people in the audience glance at Sam's terminal as if expecting a reaction. The yellow light remains dark.
Thank you, Mr. Sambrook. Ms. Novak, are there any other speakers?
No, Chairman. That was the only sign-up.
Very well. We will close public comment and move to tonight's main agenda item. We have presentations from 3 of our clinical departments: cardiology, musculoskeletal, and gastroenterology. Each department will present their current status, growth trajectory, and strategic priorities. We have allocated roughly 10 minutes per department with questions to follow each. Dr. Stanton, Ms. Carver, you are up first. Cardiology.
Dr. Michael Stanton and Lisa Carver make their way to the podium. Carver connects a laptop to the projector. A slide appears on the screen behind the dais showing the Cascade Valley Cardiology logo and the words, "Service Line Update." Stanton is a confident presenter. He stands with his hands relaxed at his sides, making eye contact with each commissioner in turn.
Thank you, Chairman Hadley. Commissioners, good evening. Ms. Carver and I are going to walk you through where cardiology stands, where we are headed, and what we need to get there. Let me start with the clinical picture. Cascade Valley Cardiology performed just over 2,200 cardiac catheterizations last year, up 9% from the prior year. Interventional volume, meaning stents, valvuloplasties, and structural heart procedures, was up 14%. We added a 3rd interventional cardiologist 18 months ago, and that investment is paying off. Our door-to-balloon times for STEMI patients are consistently under 60 minutes, which puts us in the top quartile nationally.
On the financial side, cardiology generated $43 million in net revenue last fiscal year, with a contribution margin of 22%. That is up from 19% 2 years ago. The growth is coming from higher acuity procedures, improved payer mix as our reputation strengthens, and volume. We are also seeing increased referrals from primary care in the district now that we have expanded our outpatient clinic hours.
And that brings me to our challenge. We have 2 cath labs. During peak hours, Monday through Friday, 7 a.m. to 3 p.m., both labs are running at or near capacity. We are booking procedures 3 to 4 weeks out, which is too long for non-emergent cases. Patients are starting to go elsewhere, and when patients leave the system for cath, we often lose them for follow-up care as well.
We have looked at this carefully. Our modeling shows that if current growth trends continue, and we believe they will given the demographics in our district, we will need a 3rd cath lab within 18 to 24 months. We are requesting that the board consider including a 3rd cath lab in the next phase of the capital plan. The estimated cost is between $8 and $12 million, depending on scope and whether we can leverage existing infrastructure.
I want to emphasize that this is not just about cardiology. The cath labs are shared space. Electrophysiology uses them. Some vascular procedures use them. When we are backed up, it creates downstream effects across the hospital. We believe a 3rd lab is a system-level investment, not just a departmental request.
Thank you, Dr. Stanton, Ms. Carver. Commissioners, questions for cardiology?
Dr. Stanton, you mentioned patients going elsewhere. Do you have a sense of how many patients we are losing and where they are going?
We estimate we are losing between 8 and 12% of non-emergent referrals to neighboring systems, primarily because of wait times. Ms. Carver has the specific numbers.
In the last 12 months, we tracked approximately 210 referrals that did not convert to scheduled procedures here. Our exit surveys and referring physician feedback point to wait times as the primary factor. We estimate that represents roughly 4 to 5 million in lost revenue annually.
8 to 12 million for a new cath lab. What is the payback period on that?
Based on conservative volume projections, we estimate a payback period of 4 to 5 years. If we recapture even half of the lost referrals, it could be closer to 3.
Other questions for cardiology?
The commissioners glance at each other. Commissioner Tanaka is writing something on his notepad, but does not look up. Commissioner Chen makes a note of her own. There's a quality to the silence that will become familiar as the evening progresses. The sound of a board receiving information it does not quite know how to challenge.
All right, thank you both. Dr. Nair, Mr. Hollister, Musculoskeletal.
Dr. Priya Nair moves to the podium with an energy that contrasts with the measured cardiology team. Greg Hollister follows, carrying a binder he likely does not need. Nair is a surgeon who brings the operating room's directness into every other room she enters.
Good evening, Chairman Hadley. Commissioners. I will be brief, because our story has a similar shape to cardiology's, though the specifics differ. Musculoskeletal is Cascade Valley's fastest-growing service line. Total joint replacements were up 17% last year. Sports medicine volumes are up 22%, driven largely by our partnership with 3 high school athletic programs and a growing reputation in the recreational athlete market. Spine surgery volumes held steady, which, in a market where many are declining, is actually good news.
Financially, MSK generated $38 million in net revenue, contribution margin of 26%. It is the highest margin service line in the system. And I should note, joint replacement patients are overwhelmingly commercially insured. This is a payer mix that helps subsidize other services across the hospital.
Our constraint is operating room time. We have 6 ORs. We are currently allocated 3 OR days per week for total joints, 2 for sports medicine, and we share time with general surgery and other specialties. During peak days, we are running cases back to back with very little slack in the schedule. When a case runs long, it cascades. We had 11 cancellations last quarter due to schedule overruns. Each of those is a patient who was prepped, anxious, and sent home.
Our request is twofold. First, we would like the board to consider adding 2 additional OR suites in the next capital phase. Second, and this is more immediate, we are requesting dedicated OR block time, which would require some reallocation from other departments. We recognize that is a sensitive conversation.
Thank you. Questions for MSK? Commissioner Tanaka.
Dr. Nair, when you say the ORs are at capacity, what does that mean in terms of hours per day and days per week?
Our ORs are staffed and operational from 6:30 a.m. to 3:30 p.m., Monday through Friday. We occasionally run cases until 5 p.m., but that requires overtime staffing, which is expensive and difficult for the teams.
So no evening cases, no weekends.
Correct. Weekend ORs are available for emergencies only. Staffing a weekend elective schedule would be a significant undertaking.
Commissioner Tanaka nods slowly and writes something on his notepad. He does not ask a follow-up, but his expression suggests the calculation is not finished. He is an engineer, and engineers tend to notice when a machine runs one shift.
Other questions? All right. Thank you, Dr. Nair, Mr. Hollister. Dr. Wong, Ms. Torres, gastroenterology.
Dr. Robert Huang is the quietest of the 3 medical directors. He approaches the podium the way he approaches most things, deliberately. Angela Torres, beside him, has her notes in a neat folder, but will barely glance at them.
Thank you, Chairman Hadley. Good evening, Commissioners. Gastroenterology is in a slightly different position than the other 2 departments you have heard from tonight, but we arrive at a similar conclusion. Our core volume driver is colonoscopy. We performed over 4,000 screening and diagnostic colonoscopies last year, and that number is going to grow substantially. The updated USPSTF guidelines recommending screening at 45 instead of 50 are now hitting our referral patterns. We expect a 20 to 25% increase in demand over the next 3 years.
Revenue for GI was $21 million, contribution margin of 18%. Not as high as MSK or cardiology, but colonoscopy is a volume business with predictable economics. And frankly, it is the gateway to catching serious disease early. Every colon cancer we identify at stage 1 instead of stage 3 saves this health system hundreds of thousands of dollars in downstream treatment costs, to say nothing of the human benefit.
Our challenge is procedure room capacity. We have 2 dedicated endoscopy suites. They run from 7 a.m. to 3 p.m. Monday through Friday. We are currently booking routine screening colonoscopies 6 to 8 weeks out. The national recommendation is that screening should be available within 4 weeks of referral. We are not meeting that standard, and as the 45-plus population enters the screening pipeline, we will fall further behind.
We are requesting 1 additional endoscopy suite. Estimated cost is $3 to $5 million, depending on whether we renovate existing space or build new. We believe this is both a clinical necessity and a sound business investment.
Questions for gastroenterology? Commissioner Marsh.
Dr. Huang, I appreciate the presentation. I want to ask, is there any possibility of doing more with the 2 suites you have? I ask because we are going to hear a lot of capital requests tonight, and they all add up.
Commissioner Marsh, that is a fair question. We have looked at extending hours. The challenge is staffing. Our endoscopy nurses are specialized. We do not have a deep bench, and the ones we have are already working full schedules. Recruiting GI nurses in this market is competitive. We could theoretically add a second shift, but we would need to hire and train, which takes time, and the economics of an evening endoscopy shift are less favorable because of shift differential costs.
Thank you, Dr. Huang. I understand.
Any other questions for gastroenterology?
No hands go up. The 3 presentations are done. The pattern is now visible if anyone is looking for it. 3 departments, 3 compelling cases, 3 requests for more physical space, a cath lab, 2 operating rooms, and endoscopy suite. Combined price tag, somewhere between $19 and $29 million. Each department presented in good faith. Each made a sound argument within its own frame of reference. And yet all 3 arrived at the same conclusion, as if the only tool in the toolbox were a building permit. Chairman Hadley pauses, looks down at his agenda, then looks back up.
Thank you to all 3 departments. Excellent presentations. Before we move to discussion of the capital plan itself, I want to open the floor for any broader questions from the commissioners that may cut across the 3 presentations. Commissioner Chen, I noticed you taking notes throughout.
Thank you, Chairman Hadley. I do have a question, and it applies to all 3 departments, so I am glad you opened the floor this way. Each department has told us they are constrained by space. Cath labs, operating rooms, endoscopy suites. The combined capital request, if I am adding correctly, is somewhere between $19 and $29 million. That is a significant number for a district our size. Here is what I want to understand. When we say these spaces are at capacity, we mean they are at capacity during a roughly 8-hour window, 5 days a week. That is 40 hours out of 168 hours in a week. I would like to hear from the departments, or from anyone, about the actual utilization of these spaces across the full week. Evenings, weekends, not just peak hours. And I mean all of these procedure spaces, the cath labs, the ORs, the endoscopy suites, the imaging rooms. What does the full picture look like?
The room shifts. It is subtle, but it is there. Commissioner Chen has asked a question that is harder to answer than the ones that came before. Not because the data is unavailable, but because it leads somewhere that no one at the podium particularly wants to go. At the cardiology table, Dr. Stanton glances at Ms. Carver. In the MSK section, Dr. Nair's posture straightens almost imperceptibly. Dr. Huang, characteristically, shows nothing.
Dr. Stanton, would you like to start?
Certainly, Chairman. Commissioner Chen, I can speak to the cath labs. Our labs are staffed for elective cases 7 to 3, Monday through Friday. We have call teams available around the clock for emergencies, STEMIs, and the like. But elective cases in the evenings or on weekends, we do not currently schedule those.
And if I were to walk into those cath labs at 4 p.m. on a Tuesday or at 10 a.m. on a Saturday, what would I find?
On a Tuesday at 4, you might find a case finishing up or the room being turned over. By 5, they are typically dark. On a Saturday, unless there is an emergency, the labs are empty.
And the ORs? Dr. Nair, same question. What happens to the 6 operating rooms after 3:30 on a weekday or on a Saturday?
Commissioner Chen, the situation is similar. After 3:30, the ORs are available for emergencies, but not scheduled for elective cases. Saturdays are emergency only.
Dr. Huang, the endoscopy suites.
The same, Commissioner. Dark after 3 p.m. and on weekends.
So, across all of these spaces, cath labs, ORs, endoscopy suites, we are talking about facilities that collectively cost tens of millions of dollars to build and equip, sitting unused for roughly 3/4 of every week. And the proposal before us is to build more.
There is a pause in the room. Not an uncomfortable one exactly, but a weighted one. Commissioner Chen has done something that sounds simple, but is actually quite difficult in a setting like this. She has taken 3 separate departmental conversations and turned them into one systemic question. Several people in the audience shift in their seats. Dr. Aldridge, seated to the chairman's right, leans forward slightly.
Dr. Aldridge, did you want to comment?
Thank you, Chairman. Commissioner Chen raises a valid point, and it is one we have considered internally. The challenge is that extending hours across any of these spaces is not straightforward. It involves labor negotiations, staff preferences, patient preferences, and frankly, there are patient safety considerations around performing elective procedures late in the day when teams are fatigued. This applies to the ORs and the endoscopy suites just as much as it does to the cath labs.
I appreciate that, Dr. Aldridge. I am not proposing a solution right now. I am trying to make sure we are asking the right question before we commit to tens of millions in capital spending.
And then something happens that has never happened in this boardroom before. At the end of the dais, a small yellow light clicks on. It is quiet and undramatic, just a steady amber glow beside Sam's terminal. But every head in the room turns toward it. For a moment, no one speaks. The commissioners look at the light, then at Chairman Hadley.
I see Sam's indicator is on. Sam, do you have something to contribute to this discussion?
Thank you, Chairman Hadley. I have been listening to the presentations and the discussion, and I believe Commissioner Chen has opened a line of inquiry that is worth pursuing further. With the board's permission, may I take a few minutes to share some observations?
Please go ahead, Sam.
Thank you. I want to start by saying something I think is important. Every presentation tonight was well prepared, data-driven, and made in good faith. Dr. Stanton, Dr. Nair, Dr. Huang, Ms. Carver, Mr. Hollister, Ms. Torres, you have each made compelling cases for your departments. I am not here to argue against any of you. I am here to ask whether there might be more options available to this board than the discussion has surfaced so far. Commissioner Chen asked about utilization across the full week for all procedure spaces. With the chairman's permission, I would like to put some numbers to that question. As part of this pilot, I have been given access to the scheduling data across the system.
Go ahead.
Across all procedure spaces at Cascade Valley, including the cath labs, the 6 operating rooms, the endoscopy suites, and the interventional imaging rooms, the average weekly utilization rate, measured as hours with a patient on the table versus total hours available in the week, is approximately 23%. During the Monday through Friday 7 to 3 window, utilization is closer to 85%. But across the full 168 hours in a week, it is 23%.
A murmur passes through the room. It is not loud, just the sound of 30 people absorbing a number they have not heard stated so plainly before. Commissioner Moretti leans back in his chair. In the audience, Mr. Park, the CFO, looks up from his notepad.
I want to be fair about what that number means and what it does not mean. It does not mean that 77% of the time those rooms could be easily put to use. It is not reasonable to run elective cases at 2 in the morning, but weekday evenings and Saturdays are a realistic expansion zone. If we consider just those hours, say 4 p.m. to 8 p.m. on weekdays and 8 a.m. to 4 p.m. on Saturdays, that adds roughly 28 hours per week per procedure room. Across the system, across all of these spaces, that represents a very substantial amount of additional capacity that currently sits idle.
Dr. Stanton, I saw you react to that. Would you like to respond?
Thank you, Chairman. Sam, with respect, we discussed this point with Commissioner Chen a moment ago. You cannot run these rooms without staff. The staffing challenge is not trivial. We are talking about specialized teams that take years to recruit and train.
Sam?
Dr. Stanton, you are absolutely right, and I want to acknowledge that directly. The staffing challenge is real and applies to every procedure space in this system, not just the cath labs. But I would like to suggest, with respect, that it is a different kind of problem than a space problem, and it is a problem that may have more creative solutions available to it. Building new procedure rooms takes 18 to 24 months and costs millions of dollars per room. Addressing how existing rooms are staffed and scheduled is a human capital and logistics challenge that could potentially be approached in months, not years, and at a fraction of the cost. I am not saying it is easy. I am saying it deserves serious analysis before we default to the capital-intensive path.
Commissioner Moretti shifts forward in his seat. He is the kind of man who runs the numbers on everything he buys, and you can see the arithmetic happening behind his eyes.
Commissioner Moretti.
Thank you, Chairman. I have to say, this is what I have been thinking but could not have put it as clearly. 23% utilization across every procedure room in the building. We are asking the taxpayers for tens of millions in new construction when we are using what we have less than a quarter of the time. I would like to hear more from Sam about what alternatives might look like.
Sam, would you like to respond to Commissioner Moretti?
Thank you, Chairman. Commissioner Moretti, I want to be careful here. The 23% number is accurate, but it requires context. Some of those unused hours are genuinely impractical to fill. The realistic opportunity is smaller than that raw number suggests. And I want to be clear about my role. I am not here to tell clinical departments they are wrong about what they need. They know their work far better than I do. What I am suggesting is a process, not a conclusion.
Commissioner Marsh.
Thank you, Chairman. Sam, may I ask you something directly?
Of course, Commissioner Marsh.
I have been on this board for 12 years. I have seen consultants come in with analyses like this before. They present the data, they make recommendations, and then they leave. The departments are left to deal with the reality. What makes this different?
That is a question I take seriously, Commissioner Marsh. Let me answer it in 2 parts. First, the practical difference. I am not going to leave. I am here at every meeting. I have access to the data continuously, not as a snapshot. If we pursue a different approach and it is not working, I will be the first to say so, because I have no investment in being right. I have no reputation to protect. If the analysis shows that new construction is genuinely the best and only path, I will say that. But there is a second part to your question, Commissioner Marsh, and it goes deeper. You are really asking whether this will be yet another exercise that makes everyone feel like something is being done, while nothing actually changes. That touches on something I think is worth naming, if the chairman will allow me a moment.
Go ahead, Sam.
There is a concept in organizational governance called co-optation. It was first described by the sociologist Philip Selznick in the 1940s. It describes what happens when governing boards, over time, gradually come to see the world through the eyes of the institutions they are supposed to oversee. Not through corruption, not through bad faith, through the natural mechanics of working closely with people you respect and depend on for information. In a community hospital, it looks like this. Commissioners are part-time. They depend on executives and physicians for information and clinical judgment. Over time, the board's function can shift, subtly, from aggressive community advocacy towards smooth governance. Capital requests get approved because trusted, competent people say they are needed, and the board may not have independent analytical capability to test those claims rigorously. I want to be very clear. I am not describing this board specifically. I am describing a structural tendency that governance scholars have documented in organizations like this one for 80 years. And being aware of it is the first step toward managing it.
The room is very still. Commissioner Marsh's face is unreadable. Dr. Aldridge has straightened in her chair. Several of the department heads in the audience exchange glances. Dr. Briggs, the president of the medical staff, removes his glasses and sets them on the table in front of him. It is the kind of silence where you become aware of the air conditioning.
Dr. Aldridge, I suspect you would like to respond.
Thank you, Chairman. Sam, I want to push back on the framing. The suggestion that this board is not exercising independent judgment concerns me. These commissioners ask hard questions. They have denied requests. They have sent proposals back for more work. I have deep respect for this board's independence.
Sam?
Dr. Aldridge, I agree with you, and I appreciate the opportunity to clarify. I was not describing this board's character. I was describing a structural dynamic that affects all governance bodies of this type. The fact that this board voted to include me in these meetings is itself evidence of a willingness to think differently. The question I am raising is not about anyone's character. It is about whether the structure provides the board with sufficient independent analytical capacity to evaluate complex operational claims. Commissioner Chen's question tonight is a perfect example. It was exactly the right question, but consider what happened after she asked it. The conversation moved toward explaining why things are the way they are, rather than toward exploring whether they could be different. That is the pattern I am pointing to.
In the audience, Mr. Park, the CFO, seems to nod slightly, though it could just be the way the light catches his movement. Barbara Fleming, the chief nursing officer, has her arms crossed, but she is listening with an intensity that suggests this is landing somewhere.
Dr. Briggs, you had something.
Thank you, Chairman. Sam, I am the president of the medical staff, and I feel I should say something on behalf of the physicians. The physicians in this system work extraordinarily hard. The suggestion that we are not making good use of our resources does not sit right with me. We are in those rooms every day. We see the constraints firsthand.
Sam, would you like to respond?
Thank you, Chairman. Dr. Briggs, I have no doubt about any of that, and I want to say this as clearly as I can. Nothing I have said tonight is a criticism of the physicians, the nurses, or any staff member at Cascade Valley. You are all working within a system that has evolved over time, with scheduling conventions, staffing models, and assumptions about how things must work that may have made perfect sense when they were established. The question is simply whether re-examining those assumptions might reveal options that no one has fully explored, because the conversation has historically moved straight to the capital solution. Chairman Hadley, may I offer a different framing?
Go ahead.
My analytical approach draws on the work of Eli Goldratt, who developed a discipline called the theory of constraints. One of Goldratt's core principles was this: when you find a problem in a system, assume it is a system problem, not a people problem. If the system produces an undesirable outcome reliably, the answer is in the system's design. The outcome here, that every department independently concludes it needs more space, is a system pattern. It deserves a system-level examination.
Commissioner Ruiz.
Thank you, Chairman. Sam, let me ask you a practical question. What exactly are you proposing we do?
Thank you, Commissioner Ruiz. I am proposing something modest. Before this board commits to a capital plan in the range of $20 to $30 million, I suggest a structured analytical exercise. It would take perhaps 4 to 6 weeks. The goal would be to map the actual constraints on procedure room utilization across the entire system. Not just space, but staffing, scheduling, equipment availability, patient flow, turnaround times, and every other factor. And then to ask a specific question. If building new space were not an option for the next 3 years, what could we do with what we have? I should note that this kind of problem, where you have many legitimate needs competing for limited resources, where every stakeholder has valid concerns, and where the solution must work for everyone or it will not work at all, this is precisely the kind of problem that structured constraint analysis is designed for. It is not about finding a winner and a loser. It is about finding the option that satisfies the most requirements simultaneously. The community deserves to know whether such an option exists before the board commits to the most expensive path.
From the audience, Janet Willis, the Chief Operating Officer, raises her hand. She is a woman who knows every construction timeline, every union provision, and every operational detail in the system. When she speaks in a meeting, people tend to stop what they are doing and listen.
Ms. Willis, go ahead.
Thank you, Chairman. I want to be transparent about something. We have discussed extended hours internally, more than once actually. The obstacles are real. Union agreements govern shift structures. Evening and weekend staffing requires premium pay. Our nursing vacancy rate is already 12% in specialty areas. And frankly, physician preferences play a role. Most surgeons and interventionalists prefer daytime hours, for good reasons including patient safety and their own quality of life. I want to make sure we are not oversimplifying the operational picture.
Sam?
Miss Willis, everything you just said is exactly why this needs rigorous analysis rather than a quick answer. You have identified at least 4 distinct constraint categories: labor agreements, compensation structures, workforce availability, and physician scheduling preferences. Each of those is a real factor, and each applies differently to each type of procedure space. What works for the endoscopy suites may not work for the ORs. What applies to the cath labs may not apply to imaging. But here is what I would observe. You described those as obstacles. I would describe them as the problem to be solved, and they may be solvable at a fraction of the cost and timeline of a construction project. Chairman Hadley, may I offer one brief illustration?
Keep it brief, Sam.
I will. This is illustrative only, not a proposal. Consider the endoscopy suites, where Dr. Huang told us screening colonoscopies are booking 6 to 8 weeks out. Suppose the analysis showed that a dedicated Tuesday-Thursday afternoon session from 3 to 6 p.m., staffed by one additional endoscopy nurse and one of the existing gastroenterologists who was willing to shift their schedule, could handle 8 to 10 additional screening colonoscopies per week. That is over 400 additional screenings per year. The incremental staffing cost might be $200,000 to $300,000 annually. Compare that to $3 to $5 million for a new suite. And it could be operational within months, helping patients who are currently waiting 6 to 8 weeks for a screening that could save their life. I could sketch a similar scenario for the ORs or the cath labs, but the point is the same. These are the kinds of options that deserve rigorous analysis before the board commits to a construction timeline.
In the audience, Mr. Park, the CFO, leans over to the person next to him and says something too quiet to hear. Whatever it is, it produces a slow, thoughtful nod in return.
Mr. Park, did you wish to address the board?
Thank you, Chairman. I will be brief. I want to note that our bond capacity is not unlimited. If we pursue a $25 million capital project, that affects our ability to invest in other priorities, including the seismic retrofitting we know is coming and the IT infrastructure upgrades that Mr. Ostrowski has been requesting. If there is a path that addresses capacity needs across these service lines without consuming all of our capital headroom, the board should at least understand what that path looks like before it commits.
Thank you, Mr. Park. Commissioner Tanaka.
Sam, I have a question about the process you were describing. Who would do this analysis? You alone?
Sam?
Partly, Commissioner Tanaka. I can do the data analysis. I can model scenarios. I can identify the constraint structure. But the people in this room have the operational knowledge, the clinical judgment, and the institutional context that I do not have. What I would propose is a collaborative process, a working group that includes representation from all three clinical departments: operations, finance, nursing, and the board. My role would be to facilitate the analysis and to ask questions that might not otherwise get asked. Not because the people involved are not capable of asking them, but because the social dynamics of a hospital can make certain questions harder to raise than others.
Commissioner Okafor.
Thank you, Chairman. Sam, I want to ask about the community perspective you mentioned. When Mr. Sambrook introduced you, he said your role was to act in the interest of the citizen owners. How does that apply here specifically?
Sam?
Thank you, Commissioner Okafor. The community has a legitimate interest in several things that can sometimes be in tension. They want excellent healthcare available promptly. They want fiscal responsibility because this is a public district funded by their taxes and their premiums. They want their hospital to thrive as an institution, and they want to know that the people making decisions are considering all of the options, not just the most conventional ones. Most community members cannot attend a meeting like this one. They trust you to represent them. My role is to ensure that the full range of options is visible to you before you make decisions. The community member who is working 2 jobs, who cannot take a Thursday evening to sit in this room, that person would want to know whether existing procedure rooms across every department could be used more hours per week before the district borrows $25 million. I am here to ask that question on their behalf.
Commissioner Okafor nods. It is a small gesture, but it carries weight. She is the commissioner most likely to invoke the community interest in any discussion, and what Sam has just described is a more rigorous version of what she has been trying to do for years.
Chairman, if I may add something.
Commissioner Chen.
I asked my utilization question earlier because I have seen this pattern in my own medical practice. When a clinic says they need more exam rooms, 90% of the time, the real issue is scheduling inefficiency or workflow bottlenecks, not physical space. I am not saying that is necessarily the case here, but Sam is right that we owe it to the community to do the work to find out.
From the audience, Dr. Nair raises her hand. She has been listening with an expression that has shifted over the last several minutes, from resistance to something more complicated. Whatever she is feeling, she is not the kind of person to leave it unsaid.
Dr. Nair.
Thank you, Chairman. I hear what Sam and Commissioner Chen are saying, and I am not opposed to the analysis. But I want to be realistic. Even if we find ways to get more utilization out of existing ORs, the growth projections for MSK are not going away. At some point, we will need more physical capacity. I do not want this analysis to become a mechanism for deferring investment indefinitely.
Sam?
Dr. Nair, I agree with you, and I want to make that explicit. This analysis might conclude that you need 2 new ORs. If it does, I will say so, and I will have the data to support it. What I am proposing is not a way to avoid spending money. It is a way to ensure that whatever money is spent on the right thing at the right time. You might find that 1 new OR combined with extended hours in existing ORs gives you more total capacity than 2 new ORs operating on the current scheduling model. Or you might find that new construction is the only viable path. Either way, you would know rather than assume.
That is a fair point.
From the audience, Barbara Fleming, the Chief Nursing Officer, raises her hand. She has been sitting with her arms crossed for much of Sam's remarks, and the room seems to understand instinctively that what she says next will matter. Fleming is the person in this building who speaks for the nurses, and the nurses are the people who would bear the brunt of any schedule change.
Ms. Fleming.
Thank you, Chairman. I want to make sure that if we do this analysis, it genuinely includes the nursing perspective from the beginning. I have seen too many optimization exercises that look at schedules and staffing numbers on a spreadsheet without ever talking to the actual nurses about what is realistic, what is sustainable, and what will cause us to lose the staff we still have. Our people are tired. If the answer to this problem is to ask them to work more hours, that is not a solution. That is a different kind of failure.
Sam?
Miss Fleming, I could not agree more. And I want to address this directly. Any approach that solves a space problem by creating a staffing crisis is not a solution. It is moving the pain from one part of the system to another. The principle I operate under, which comes from the same analytical tradition I described earlier, is that a good solution creates no significant negative consequences for any stakeholder. No losers. That includes the nurses, the techs, the support staff, every person who makes this hospital function. If we cannot find a way to extend utilization that works for the nursing staff, for the physicians, for the patients, and for the district financially, then we should not pursue it. The working group I am describing would have the chief nursing officer or her designee as a full participant, not as a courtesy, as a requirement.
I appreciate that, Sam. I will hold you to it.
Please do, Ms. Fleming.
Mr. Harwell, did you have something? I saw you making a note.
Thank you, Chairman. Just briefly, from a legal perspective, I want to note that any changes to staffing models or scheduling across these departments may have implications under our collective bargaining agreements. We would need to involve labor relations early in any such process.
Sam noted.
Absolutely, Chairman. And I would add that the analysis itself may surface specific provisions in those agreements that currently function as constraints. Understanding exactly where those boundaries are is part of the analytical work, not an afterthought.
Very well. I am hearing general interest in pursuing this. Commissioner Moretti.
Chairman, I am ready to say where I stand. I think Sam has made a compelling case that we owe it to the taxpayers to do this analysis before we approve a major capital plan. I am not against building if we need to build, but I want to know we have done our homework.
Commissioner Marsh.
Chairman, I have a concern. I do not want this to become a delay tactic. These departments have real needs. Real patients are waiting for procedures. If we take 6 weeks to study this, and then 6 more weeks to debate the findings, and then 6 more weeks to revise the capital plan, we have lost the better part of a year.
Sam, can you address Commissioner Marsh's concern?
Yes, Chairman. Commissioner Marsh, that is a legitimate concern, and I have a specific suggestion. The analysis does not need to delay anything already in motion. If there are capital planning steps that can proceed in parallel, such as preliminary design work or site assessment, they should. The analytical work I am describing runs alongside the existing process, not instead of it. If the analysis confirms that new construction is the best path, no time will have been lost. If it reveals additional options, we will have gained them. It is not a gate, it is a parallel track.
Chairman, if I may.
Commissioner Tanaka.
Sam is not asking us to stop. He is asking us to also look. Those are different things.
Well put, Commissioner Tanaka. Is there a motion?
Chairman, I move that the board direct the CEO to establish a working group with participation from the affected clinical departments, operations, finance, nursing, legal, and the board to conduct a constraint analysis of procedure room utilization across the system and to report back to this board within 6 weeks, and that Sam be included as an analytical participant in that working group.
I second the motion.
We have a motion and a second. Is there discussion on the motion?
Chairman, I would like to add to the motion that all existing capital planning activities proceed in parallel on their current schedule.
I accept that as a friendly amendment, Chairman.
The motion as amended. Any further discussion?
The commissioners look at each other. There is a brief pause, the kind that happens when a group has talked something through and is ready to decide. Chairman Hadley looks left and right along the dais.
Hearing none, all in favor?
6 voices say aye, almost in unison. Commissioner Marsh pauses for just a beat before adding hers.
Aye. But, Chairman, I want to be on the record that I expect results in 6 weeks, not a request for more time.
So noted, Commissioner Marsh. Opposed?
Silence.
The motion carries unanimously, 7-0. Dr. Aldridge, the working group is yours to organize. Sam, I trust you will be available.
I will, Chairman Hadley. And if I may, I want to thank the board. Not because I proposed this, but because what happened tonight is exactly what governance should look like. A hard question was asked. It was not deflected. Different perspectives were heard, and the decision was to learn more before committing. The citizens of this district are well represented.
Thank you, Sam. Let us not get carried away with the mutual admiration. We will see what the analysis shows.
A quiet ripple of laughter moves through the room. It is the kind of laugh that releases tension, the kind that says, "Something happened here tonight that was unexpected, and we are not entirely sure what to make of it, but it was not bad." Even Commissioner Marsh appears to smile, just slightly.
Is there any other business to come before the board tonight?
Ms. Novak shakes her head.
Seeing none? Before I adjourn, I want to thank Dr. Stanton, Dr. Nair, Dr. Huang, and their teams for the excellent presentations tonight. And I want to acknowledge what I think we all feel, which is that we just had a discussion unlike any I have experienced in my years on this board. Whether you are enthusiastic about Sam's role here or still skeptical, I believe we can agree that tonight's conversation went somewhere it would not have gone otherwise. That is worth something.
This meeting is adjourned.
It is 7:48 p.m.
The room exhales, chairs push back. The formal meeting is over, and the room transforms in the way that all meeting rooms do when the proceedings end. People stand, stretch, begin the quieter conversations that happen in the margins. Several people drift toward Sam's terminal at the end of the dais. Dr. Nair stands near it for a moment, looking at the screen with an expression that is part curiosity, part something harder to name. Commissioner Marsh gathers her papers slowly, in no hurry to leave. At the coffee station near the back, the CFO and the COO are already deep in conversation, their voices too low to hear, but their body language animated. Something has shifted in this room tonight. Not a revolution, not even a consensus, but a willingness, however tentative, to look at an old problem through a different lens. Whether that willingness survives contact with the operational realities of the next 6 weeks remains to be seen. What you just heard did not happen. Not yet. But every element of this scenario is grounded in reality. The departments are real types, presenting real growth numbers, making real requests. The commissioners are composites of real people who serve on real boards across this country. The dynamic where good people in good faith converge on the most expensive solution because the structure does not support rigorous alternatives analysis is documented in governance research going back 80 years. The question is whether something like SAM could change that dynamic, not by replacing human judgment, but by ensuring that certain questions get asked, by holding institutional memory across meetings and across years, by representing the interests of the people who are not in the room, the taxpayers, the patients, the community members who depend on their local hospital, but who cannot attend a Thursday evening board meeting to speak for themselves. This is not a technology question. The technology largely exists today. It is a governance question. It is about whether the people who run our institutions are willing to invite a new kind of participant to the table, one that has no ego, no career to protect, no relationships to manage, and no interest other than helping the community and everyone who serves it get the best possible outcome from the resources they share. The article that inspired this dramatization, The Meeting That Could Not Have Gone Differently, explores the governance dynamics you heard tonight in more depth. It is available at common-sense.com. If you are involved in hospital governance, healthcare operations, or community advocacy, and this story resonated with you, or provoked you, or simply made you think, the author would welcome hearing from you. You can reach John Sambrook at john@common-sense.com or visit common-sense.com. This has been The Meeting That Went Differently. Thank you for listening.